One of the things we're trying to do is, you talk about making the patient more responsible, but what we're trying to do is we're trying to get a level of information down to the PCP, so that the PCP could monitor the patient in a more proactive manner. So at Hartford, we're trying to get the specialists to take care of the tertiary work that happens in the hospital, and to make sure that gets down to the individual's PCP. And it's interesting. I'm actually in meetings with the specialists that want the PCP to be responsible, so that the PCP knows what's going on, knows if there's any interaction with other providers that the specialist may not know about, and really being a coordinator of care. So, at Hartford, that's where we're trying to focus on now. It's not the patient, but it's one level taken away from that, and look at the PCP to do that. So,
and I think that's where we've got a good opportunity with the technology, providing EHRs across all of the care settings. So every one of those physicians from specialists to primary care are using the same system to see the same data.
But then we got to change the reimbursement model, because there was one cardiologist. He says, "I'm the person's PCP." He doesn't want me. He says, "I'm the only one he sees." So we really have to change the payment method, and it appears, and this is just conjecture on my part, it appears that if a facility owns their physicians, it's a little bit easier than with us. We do with some owners of non-owned, because a non-owned physician doesn't want to lose his revenue by taking more time checking to see that everybody's able to see the correct and stuff like that. We can do that with information technology, but it's still the process of you're still maybe taking away time from this person, so you really are doing it on better outcomes. So we have to change that methodology.
The challenge is, this technology can't solve is the permissions and the HIPAA and the opt-in and the opt-out. So, in this other organization I mentioned, where different health plans and providers are sharing data, we've had long, heated discussions about how much opt-in, how much opt-out, how much can you share. I mentioned someone's on vacation and has an accident. Is that person given permission for that information to be shared? And that's the role that legally that she has currently gone down, is that people have to opt in. And how do we get them to opt in? We have brochures in the doctor's office asking them to sign them, and we go on these campaigns to do it. But to get people to proactively do something is very difficult. You can't opt them in and give the opportunity to opt out. They have to opt in.
You talked about that. Had the fast food industry basically only had a brochure as their advertising, we probably wouldn't be in this condition today that we're in. Basically, from a marketing perspective, healthcare is not out there marketing themselves. We have individual organizations in local areas that they basically do healthcare advertising, and it's very limited. It doesn't even compare to what you see from a Wendy's or a McDonald's or any of those that we do. So we're not out there competing. We're not counteracting the effects and the things that are coming in. We don't advertise this. We don't give them an opportunity to opt in on a regular basis. I mean, we're starting to see car insurers now that are willing to put devices in there. If you put a device in there, we're going to give you a rate break.
Right.
They tell us how to drove. Well, let's find out how they live and give them a rate break.
So now it's interesting. If you look at, say, the auto insurance market, Progressive has this little device that you plug into the OBD2 port of a contemporary vehicle, and it records all of vehicle dynamics. And after 30 days of that, they'll look at the data. And based on the data, if you're a good driver, you'll get a discount. Do you guys foresee a point in time where we do consumer pricing that same way, where a consumer is going to receive benefits for opting into this data environment? They're going to receive benefits for making healthy choices, or is it going to be more the stick later in life for people that have some of these chronic health conditions because they haven't taken care of themselves?
I would say I think it's already started in a small way where it's not a stick right now, it's a benefit. I give an example in our organization. If you go through these certain wellness, certain fitness kind of things, you get a $20 discount each month on your membership. It's just a small thing, but it's a step in the right direction. And I think those are the things that are going to have to proliferate for that consumer to be a bigger part of this equation.
Right.
Yeah, I agree with Ken. Same thing in our organization. Actually our payers are providing some of that, and Hartford Hospital itself is looking at population health within its own employees.
Right.
I don't believe we set any incentives around that yet, because we're just going to be beginning to look at that. But we're going to look and provide education programs and those types of activities for people that have certain disease states.
I think the incentives work, but you have to be careful. I mean, we do some health and wellness incentives, and as long as they're minor, when you stop and think about insurance, it only takes 2 or 3 catastrophic hospital cases. You have to have some money to cover that. If you're giving refunds to all the healthy people, you don't have enough money to cover it. So I think the risk on car insurance is very different than the risk on insurance. You know, so he can pay twice as much for his car insurance because he's a bad driver, but it doesn't work that way with health.
That's right, exactly.
But the perception is huge, and little incentives. It's amazing what people do for an extra $25 or $50 in the premium.
I'm not sure that it will happen quickly enough. One of the issues that the well already paid for the sick today.
Right.
So how are you going to get that? You're going to reward them for being healthy, but at the same time, somebody's still got to pay for the sick. And the government's not doing it right now, really.
Right.
So,
Yeah.
it's, how are you going to get there? There's got to be a change in the government funding of Medicare. Medicaid has got to change. There's got to be some ownership from everyone on this to even get that to start to do, because we're going down that way. How far is it really going up? It hasn't changed anything. You're still paying for the sick.
Right. And so let's stick with that for a minute, because I think if we look at reform, I mean, we seem to spend a lot of time kind of pushing money and responsibility and liability around between physicians, providers, and payers. We don't necessarily spend a lot of time talking about government and consumer. And now we're in a situation where to at least 2 of the 4 of you up here might wind up inheriting this classic obese, diabetic, hypertense, elderly patient, no real history with a PCP, never had a real healthy day of lifestyle in their life, and now you have to provide them coverage, you have to provide them care, you have to keep them out of the hospital to make your post-discharge bonuses. Are there elements of reform here that just are not going to work in the near term, or are there changes of reform that we need to push more of this on the consumer? And I guess what I put to you guys is, if there was one aspect of reform you could change, what would it be? I mean, how would you make this a better plan if you could get out there and twist one of these dials?
Well, it wasn't health reform, it was health insurance reform.
Yeah.
I mean, that's the basic problem. They dealt with the funding of it and basically tried to extract money from others to help pay for them. And, when President Obama said, if you like your health plan, you can keep it. Well, that's wonderful if your health plan can stay in business, but when you're, as a health plan, competing with other plans that don't pay as much of their way, it's tough to make the economic model work. So, for example, if the providers decide that this operation costs $1,000 and Medicare pays $800, who pays the other $200? The commercial plans pay that. I mean, that happens today. That's reality today, and that's in our premiums. And so it just doesn't make economic sense if you start running the health plans out of business where the employers are already paying 110, 120%. It's broken.
One of the other things that I think would, and maybe it's already changed in the final one, I'm not 100% sure, but if we're going to manage the care for that patient, I don't know how we can do it without the data. So if the patient has the ability to opt out and not share their data, I don't know how we're going to be effective in that process. So that's one thing. And then the others would be, to your example, I think if there's some risk adjustment, call it a spiff, if you take on that elderly patient with all these other issues, so to speak, that the reimbursement model is different for that somehow, some way.
So is there, a requirement that we start to personalize this a little more from both a cost and a responsibility perspective? I mean, it seems now that everyone is included by mandate. Should there be more of an earn-in here? I mean, if you want to be covered, do you at minimum need to establish a PCP and go see them and become engaged in the system? Is that a flaw maybe as we've implemented it today?
Well, I think we're trying to have a free society that goes against being able to provide health care at a reasonable cost. Because if you let the healthy people, right, opt out,
Right.
then you will not have their data. They will not be in an insurance plan potentially, and then they only opt in when they're in trouble. So maybe they take the first year, they take the hit on the first year. I mean, that's capitalism to do that.
Sure.
So, yeah, I mean, I think it's not an easy question. I mean, but there was one thing I agree with Ken, I would like to see the opting out a lot more difficult.
Okay.
We really have people opt in, maybe that's a condition of some sort of insurance or an insurance break or something like that, because there has to be something that, will help, in essence, the population in general.
Right.
To be able to get
Right. Now, and certainly, I mean, one of the things that would help here is if we could do more in lower cost care settings, and we see that over and over again. If we could keep people in their home, if we could manage people remotely, if we could get them engaged in some form of telehealth or remote monitoring where we could keep track of them. Again, now this seems to be one of those challenges of everyone agrees that there's some potential benefit there, but there's no obvious ownership of responsibility there.
How is the insurance company?
Yeah, okay. All right, perfect.
Beyond providers, beyond insurance companies, the question I asked Ian at this presentation, I think Sunday evening, was what's the role of the public health system? And he said, yeah, we should tax solar pop. Yeah, let's tax solar pop. That's not your problem, that's not our problem. Let the government take heat for that. Let's get some money by taxing solar pop. There are things at the more macro level that can have a significant impact on the health of our population.
So you want to take that to a complete risk-based way. You say add a tax to soda pop, but then you've got the extreme sports people. You tax them because they put their lives at risk and do that. I mean, it's not just soda pop; it's everything else too.
Right.
So you got to think of it. Should there be some type of regulation? Probably. What should it be? I don't think anybody's got a great definition of that right now. I mean, you got Democrats who want to take care of everybody. You got the Republicans who don't care about anybody. So that's just where we're at.
So does it? Go ahead.
Well, I was just going to say, I think there's a lot of value in moving these things. You look at the progression from the inpatient to this specialist to the primary care to the home, etc. I mean, that is happening. It's going to continue to happen. And we get into telehealth. There's certainly going to be some value in that. I keep harping on this. But the consumer has to have some risk in this equation. So we could give them all these tools. We could give them all of this data that they're getting from these different monitors and all these things. If they don't understand the why, number one, of why this is important, that they use this monitor, or they follow this data, or they manage their health, I mean, it's not going to do us anything. So they have to understand the why. And to get some of the consumers to understand the why, they've got to have some risk in this equation, or they're not going to change their behavior.
So now, it would seem to me, though, that there's a tremendous challenge here. We're talking about people that are not currently insured, that don't live healthy lifestyles, and yet we're going to try to create some kind of either incentive or penalty to cause them to change behavior. And I have to question whether that's realistic. I think if I've kind of lived my whole life poorly outside of the health system, it would seem really difficult to change that behavior. I mean, does there need to be some recognition of the fact that 10% of the population here is just going to be dragged kind of kicking and screaming through this new system, and there need to be different rules and different reimbursements, or are we all just going to figure out how to cover that cost as part of our other operations?
If it was going to be 10% of the people, I'd say let the revolution begin.
Yeah.
But it's not.
No.
It's going to be more than that.
Yep.
You're going to have this, no matter which way you turn right now, until we have changed the thinking of the consumer. And we just haven't done a consumerism piece for healthcare. We're not there. If we were a Apple or a Microsoft, consumerism is what we're after. We're not there. We've got to get there. We've got to change thinking. That's what they did. They changed thinking.
Right.
They had innovators inside that changed the thinking